Hello everyone. In this video we're going to have a little recap of atrioventricular blocks. Difficult to talk about atrioventricular blocks without talking about the PR interval. So before we get into it, I would like to mention something that it might be a little bit confusing. So when we are looking at heart blocks, we are looking at the PR interval, but sometimes that gets confused with the PR segment. So what we are looking at is the PR interval here. Okay, the PR interval is calculated from the beginning of the P wave, just here, to the beginning of your QRS complex. What does that mean? That a PR interval is from the beginning of the depolarization of your atria all the way to the beginning of the depolarization of the ventricles. The PR segment, instead, it's calculated again in milliseconds. It's a flat line between the end of the P wave and the beginning of the QRS complex that simply signify the little delay that there is in the conduction between the atria and the ventricle. That is not the one that we are interested in. The one we are interested in is the PR interval, and as we know, the PR interval should really be less than 200 milliseconds, or about 3 to 5 small squares. Said that, let's move on to our first AV block. So first AV block, it will be obviously our first degree AV block. So what is a first degree atrioventricular block? The first degree atrioventricular block, it's simply when there is a delay without any interruption in conduction from atria to ventricle. So really the problem is here in your AV node, where there's a delay in conduction, an abnormal, I might say, an abnormal delay in conduction. Now, how does this reflect on an ECG? Simple, really. So if we have a look at an ECG strip, a delay in a conduction between the atria and the ventricle shows in an increase in our PR interval. So how do we calculate that? I'll be very careful. Again, a PR interval will be calculated from the beginning of, here we go. It's going to be calculated from the beginning of your P wave. So first of all, we identify all the P waves. There's a P here, P here, P here, and a P here. And the beginning of your QRS complex. And then you simply just count the small squares in between. Yeah, 1, 2, 3, 4, 5, 6, 7, and 8, probably. Here again. Go 1, 2, 3, 4, 5, 6, 7. So you see in all of this, here, a little bit back. In all of these ones here, we are looking at a PR interval that is more than 5 small squares. So what else we got here? 1, 2, 3, 4, 5, 6, 7, 8. So we said 8 here, 8 here. There's another one right there. 1, 2, 3, 4, 5, 6, 7, and an 8th one there. So here we go. So we've got a relatively regular distance between my P wave, between the beginning of the P wave and my QRS complex. When this happens, that is your first degree AV block. moving on. So what's happening? The next one we're going to look at is our, quite naturally, our second degree AV block, type 1. Also known as Mobitz 1, or also known as the Wenckebach phenomenon. So what happens here is slightly different. So your AV node, your action potential will still generate in your AV node, and the action potential will travel no problems in your internodal fibers and through, obviously, through your Bachmann bundle, and reach here your AV node. So in Mobitz 1, so in your second degree type 1 heart block, it's usually caused by a reversible conduction block at the level of the AV node. Essentially, what does this mean? This means that malfunctioning AV nodal cells tend to progressively fatigue until they fail to conduct an impulse altogether. So from this point here at the AV node, these cells, they get slower, and then suddenly they just stop conducting all of a sudden. What can cause that? Sometimes drugs like beta blockers or calcium channel blockers, digoxin, amiodarone, and all the rest can cause this phenomenon. Increased vagal tone, an inferior MI, myocarditis, sometimes could be something that happens after cardiac surgery, and so on. So there is different causes of it, and that's what happens. So that the cells, the nodal cells, the AV nodal cells, they get progressively fatigued until they stop conducting altogether. So what does that look like on an ECG? Here we go. We'll have a look at our ECG here. So once again, we'll try to identify. Here we go. There's a P wave here. There's another one here. Another one here. Another one here. And there we go. And last one here. So what's going to happen there? So here we have a look at my PR interval once again, from the beginning of my P all the way to the beginning of my QRS complex. And I think here we're looking at roughly 1, 2, 3, 4. So this one is pretty good. We'll do the same here. 1, 2, 3, 4, 5, 6. So here we get 4 small squares. Here we've got 6. We'll have a look here again, and that's 1, 2, 3, 4, 5, 6, 7, 8. 8 small squares there. And then progressively, the P, there is a whole QRS complex that is missing altogether. So as you can see, there was a prolongation in my PR interval, and then a beat gets dropped altogether. And this is my second degree AV block type 1, or Mobitz 1, or Wenckebach phenomenon. Natural follow-up from this would be talk about our second degree AV block type 2. You go, also known as your Mobitz 2. So what happens during your AV block at you're doing your Mobitz 2? Basically, in this case, it's a form of a second degree AV block in which there is an intermittent non-conducting P wave without progressive prolongation of the PR interval. So it's the same thing as your type 1, but that is the PR interval remains the same. This means what? This means that the PR interval in the conducted beats remain constant, and the P waves seem to, what we say, march through at a constant rate. The RR interval surrounding the dropped beats is an exact multiple of the preceding RR interval. For example, it would be double the preceding interval for a single drop beat, or triple for 2 drop beats, etc., etc. So what usually happens here? So why does this occur? So Mobitz 2, it's usually due to a failure of conduction at the level of the Purkinje system. So this is below the AV node. So the conduction issue is here, while during type 1 we said that the conduction issue was during nodal cells. During second degree AV block, the issue is here in the Purkinje fibers. While Mobitz 1 is usually due to a functional suppression of the AV conduction, Mobitz 2 is more likely to be a structural damage of the conducting system. Often patients have a left bundle branch block as a coexisting feature for this. The second degree AV block is produced by an intermittent failure of the remaining fascicle, really. So if you've got a block already, whatever is left of these fascicles that are still intact, usually they are an intermittent failure of it. That's what causes your second degree heart block type 2. In about 75% of the cases, the conduction block is located distal to the bundle of His, producing a broad QRS complex. And in the remaining 25% of the cases, the conduction block is located within the His bundle itself, producing a narrow QRS complex. So these would be the clinical features that we would see. So what it would look like on an ECG. So here we go. Let's have a look. Again, let's have a look at my P wave, P wave, P wave, P wave, P wave. So here we are not expecting a prolongation of my PR. Here we go, this one here. Here, I would say P here. So what we've got here, 1, 2, 3, 4. 1, 2, 3, 4. And go on here and here. 1, 2, 3, 4. So here we go. So this is actually pretty accurate. 4. So that is a constant distance on my, so there's a constant PR interval until my bit is dropped. And this is my second degree AV block type 2 or Mobitz 2. And finally, we're going to talk about my third degree AV block. So what's my third degree or a complete heart block? So the complete heart block usually comes in with severe bradycardia due to an absolute absence of AV conduction. Okay, so this conduction here is just not going to happen. The ECG will demonstrate a complete atrioventricular dissociation with completely independent atrial and ventricular rates. What does that mean? That if you have a look, if you count the rate from your R waves, so your RR rates, it will give you something. But if you count the rate from P wave to P wave, it's going to be completely different. A complete heart block is essentially the end point of either a second degree type 1 or a second degree type 2 heart block. It may due to progressive fatigue of your AV nodal cells, like your Mobitz 1, or alternatively, it might due to a sudden onset of complete conduction failure throughout the Purkinje system, like your Mobitz 2. This can be due to a septal infarction, for example, or an acute anterior MI, or a trifascicular block, or this can also be due sometimes to some AV nodal blocking drugs, like calcium channel blockers, beta blockers, digoxin, and so on and so forth. So this is quite an important rhythm to be able to recognize. Now, how would you recognize a third degree heart block? A third degree heart block is simply identifiable by a complete dissociation of your P waves to the rest of the QRS complex. So there is no pattern there. So if I was to recognize here we go. This is my R wave, R here, and my P waves instead of here. That is one here because this one here really it's because this one here it's a T wave. Really here that's a T. That's another P here, P here, one there, one embedded in these two ways. So as you can see, there is no real pattern associating them. Okay, and that is the identifying feature of a third degree heart block. So in summary, in your first degree AV block, your PR interval is simply elongated. So it's going to be always more than 200 milliseconds or 5 small squares. As you can see here, which actually I just noticed that here I skipped one. So it actually makes 8 as well. Brilliant. So that is your first degree AV block and is due to a delay in conduction in your nodal cells. Your second degree type 1 or Mobitz 1 or 1 Quebec phenomenon is also due to a progressive fatigue of your nodal cells in your AV node right here, and is characterized by an elongating PR interval. So you can see here 4, 6, 8, and then it dropped a bit. So there's a PR interval gets longer and longer, and then a bit gets dropped, and it's just a progressive fatigue of your nodal cells. Your second degree AV block type 2 instead, the problem is in your Purkinje system. So anywhere from your Purkinje fibers all the way down here, somewhere the problem is somewhere there in the fibers there, which means that is more like a structural damage of your fiber, the issue. And here what we find a regular PR interval, which doesn't have to be an elongated PR interval. So here is a perfectly normal PR interval, but then suddenly you have a drop beat. So there is no elongation of a PR interval and then a drop beat. That is your second degree AV block type 2, and this is due to a structural damage of fiber cells in your Purkinje system. And your third degree heart block is usually associated with quite a profound bradycardia, and it shows as a complete disassociation between your P wave and your R wave. Your AV node is not really conducting anything. So really your signal to depolarize the atria is no longer coming from your AV node, but is coming from other cells from around the heart. And that's why your P wave is scattered all over the place. And that's your 3rd degree AV block. I hope that this has been useful. As always, just get in touch if you have any questions. Thank you.